Hi folks, this is Dr. Cywes, and today's going to be a pretty cool video because I'm pretty proud of my level of experience and understanding. And I know that may sound a little arrogant, but I work in the trenches of metabolic health. And one of the things that I do, I see tons of patients. We see a lot of patients every day. So we have huge volumes of experience, and everybody in our space pretty much is coming to us for metabolic health reasons. And as such, we see a full spectrum of people. And when you go on the internet in the space, there's a lot of advice, a lot of knowledge, but a lot of that knowledge is fairly static. And it's the biggest comment or criticism I have in our space, and it's an evolving space, and I think it'll get better, is that very often the people on the internet, even the friendlies in our space, look at an algorithm of health. And they have a particular algorithm that they believe you should try to attain and fit into. And that is true to a certain extent, but that algorithm is not an endpoint. It's a continuum. And yes, we strive to improve health markers in our blood work, but so often the people on the internet are looking at individual numbers. And instead of looking at individual numbers, when I order blood work, it's always extensive. It's always extensive. When you get blood work from me, and you always will, it's going to be extensive because I use the blood work to tell a story. And one number influences the other. And sometimes if you look at single numbers that you see on the internet, they can upset you. And today is such a story. Okay? So, and I've gotten permission from these two folks. They just happen to be within a couple of days of each other and have the same pattern. And this is where I'm going to expose some of the adamant stuff that you will hear on the internet, even in our space. Folks, you know, I don't wear scrubs just because. I wear scrubs because I'm a surgeon. I'm not operating right now. But last night, I was operating. We sometimes have to respond to emergencies, and I had a long day, and I was dragging. And I want to be at my top of my surgical game. I want to be focused and attentive when I'm operating on someone, when their lives are in my hands. And I knew I was dragging a little bit. I knew that I wasn't going to be eating through the day. And I didn't want to do that, but I didn't want to disservice my patients. So about half an hour before we started the surgery, I hit one of these ketone IQs. Now, did I need to? No. I've got 30 years of surgery behind me. I can do that. But here's what it did. It got rid of a little bit of hunger. It helped me to hone in and focus, got me into ketosis where I'd even killed energy. And I was really alert, really awake, and able to focus and did my best job with that patient. And the beautiful thing is, after I did that emergency surgery, after I saved that patient's life, and I saved patient's life. No, this is a true life-saving experience. That patient did brilliantly well, and he's going to go home later this morning. That's what we do, and this helped me. Try it sometimes when you're hitting a speed bump in your life and you need focus and you need energy. So we know that cholesterol and LDL numbers really do not correlate with cardiovascular disease. We know that categorically, okay? Whether your cholesterols are high or low doesn't correlate with cardiovascular risk, and artificially lowering them doesn't do that. The marker, and this is important, folks, the marker that most strongly correlates for most people with metabolic health or illness is your triglyceride number. It's a marker, okay? So typically, high triglycerides, and triglycerides come from the conversion of sugar to fat by the liver. High triglycerides correlate, are a marker of do not cause. So treating triglycerides are useless, at least with medication. High triglycerides typically correlate with a high index of cardiovascular risk, plaque formation and cardiovascular risk. And one of the objectives of the ketogenic diet is to lower the triglycerides. And my personal threshold in terms of the therapeutic arm is to lower those triglycerides down to 75 or lower with a high HDL. I want an HDL 75 or higher. Okay? And that typically is a marker of recovery from insulin resistance. So if you think about this, if insulin resistance is a hole in the road, and you have a flashing red light that says, hey, there's a hole in the road, that flashing red light is your triglyceride count. It's not the cause of the hole in the road, but it's saying, dudes, there's a hole in the road here. Okay? And if you correct that hole in the road, typically you should be able to switch off the light. Okay, and that's the correction of insulin resistance, becoming insulin sensitive, which is really the holy grail, the passage for metabolic health. We know that. Okay, and that everybody on the internet is talking about triglycerides and all those bobbleheads. I call them that. I'm one of them. Good friends of mine, people that I listen to, people that I admire, mentors for me. The holy grail is to get a low triglyceride. So this week I have two patients. Know them well, been with me for several years. Both of them have high triglycerides. Both of them have high triglycerides, and they're petrified. And here's why they're petrified. Because they have done everything right to not have high triglycerides. They've done everything right to be insulin sensitive. So how the hell can their triglycerides go be high? And everyone says high triglycerides correlate with high cardiovascular disease. And my first person is a male in his 50s, and he has a history, folks. Listen to this history. This is before he went keto carnivore. And he's primarily carnivore right now. He has a history of hypertension, of angina, of left anterior descending artery, of cardiovascular blockage to the point that he needed a stent. He has stents in his heart. He has extensive plaque disease. He has a high CAC score, and he has had a history of atrial fibrillation. His 5'11" has never been his highest weight, 175 pounds, which is underweight at 5'11". Never been fat, never been obese. In fact, been on the skinny side. Currently weighs 153. And he's been on a carnivore diet for several years and on a strict carnivore diet. He had a stent placed 7 years before, but he is obviously petrified of cardiovascular disease. And he's had a huge fight with his cardiologist about not being on a statin. And he comes in and he says, man, I'm doing everything right. Everything right. Everything right. And yet my triglyceride count is high. This diet is bad for me. I'm afraid. And he's just saying, I'm afraid. Because all the other parameters have gotten better. So what's going on with him? Why is his triglyceride level high? What is he doing wrong? And in fact, we even experimented a little bit with trying to use metformin, which is a glucose release blocker, to see if we can bring his numbers down. So I've got his numbers. I'm going to go through that with you. Then I have another patient, a female patient, also in her 50s. Okay? She's been slightly overweight. 5'1", is a high, not enormous, but overweight. And it's kind of stayed there. Has had more of the thyroid, the autoimmune disease, has had more sort of kind of the obesogenic side of things, but also has a high triglyceride count and is worried about it. Also on a BBBE, on a carnivore diet, done very, very well for several years. Why does she have a high triglyceride count? Are we wrong? Is our diet wrong? So let's go through this, and I'll start with the male, and we'll do some comparisons. So the first thing, and this is what his cardiologist says to him, dude, you're going to die. You're going to have a heart attack pretty quickly. Why? Because your total cholesterol is 372. 372. Your LDL cholesterol is 267. Remember, they want it below 80 or 90. 267. High. Now, my range for that is 120 to 300. My range for cholesterol is typically anywhere above 200. I'm not too worried about a 372. So I'm not worried about those two numbers, but the cardiologists are having heart attacks on behalf of this person. Next number, HDL, 75. Now, my practice, I know Dave Feldman has a slightly different number. We're in the same ballpark. My target for HDL is 75. And HDL gets produced during utilization phase under the influence of glucagon when you're not eating, okay? HDL 75 is your healthy cholesterol. Triglycerides. Ideally, I want those below 75. His triglycerides are 142. 142. Now, most doctors are going to look at that. The upper limit of normal on the range is 150, but I want that around 75. So most doctors, that's okay. But he's petrified of that because he knows in our space those are high. And why the hell are they high if he's eating carnivore? What's the problem? So I said, okay, the 142 is a flashing red light. It's a problem. There's something going on. Let's figure this out. And this is where the story comes in. So you have to look deeper in the numbers because we focused on the lipid numbers. Now, what most doctors in this space are going to do, they're going to do lipid layers, a PLA2 layer, you've got to fractionate, and you want particles. Bullshit, you don't need that. And I'll prove to you why you don't need that, because they're going to tell a false narrative. And I argue with my colleagues, you do not need to do the NMRs and the Boston Heart blood work and spend all that money and analyze particle sizes and bullshit, you don't. You got to look at other numbers. You've got to look at the hormonal numbers, and you've got to look at the carbohydrate insulin numbers. So let's look at this guy. I trust his diet. I know he's lost a substantial amount of weight. I trust what he's done. Actually, he's only lost about 20 pounds because he was never fat. But that for him is still a substantial weight. Okay? So let's go through the rest of the blood work. I said, pump the brakes. Okay, now this is early morning fasted blood work, about 8 to 12 hours of fasting, and he's a carnivore. Blood sugar. Now in your head, when I mention these numbers, decide for yourself what you think the number is going to be. Blood sugar, 79. This is dawn effect. This is early morning fasting blood sugar is 79. Blood sugar is 79. Okay, that's a blip. But 79 is actually a perfect number for me up to the 80s. So I'm okay with it this being in the 80s. But 79 tells me it's low. And if the triglycerides are coming from the conversion of sugar to fat, how the hell can you have a 79 with a 143 on the triglycerides? Okay? Doesn't compute. Next number, and I've talked about this and I'll talk again about this, BUN, creatinine, GFR. BUN is 17, GFR is 0.96, and his creatinine is 0.96 and his GFR is 94. And he's fairly lean, small guy. Tall, but not very heavy. So BUN, creatinine and uric acid, directly reflect protein wasting. So remember, in a carnivore, their blood sugar is going to come from protein. And there's two sources of protein. Dietary protein, excess protein from in the diet, excess amino acids being turned to sugar by the liver and being turned to triglycerides, and from his own muscles. When you break muscle down, we break tissue down, that protein can be repurposed or turned into sugar and stored as fat. And the BUN, the nitrogen component, gets cleaved off of amino acids when they get used for energy, and we pee that out and we can measure that. So the BUN is a direct measure of whether he's eating adequate, too much, or too little protein. Okay? So his BUN is 17. My normal range is 18 to 22, but I'll take into account that he's fairly lean. He is carnivore. He's a high-fat carnivore. I would consider that BUN to be slightly low normal, but for him in the normal range because he's lean. Now, let's look at this woman. Okay, I'm going to stop there. I'm going to look at some more numbers with both of them, but let's catch up with this lady. Okay? Cardiologist probably needs to do CPR and shock themselves when they see these numbers. Okay? First thing, total cholesterol, 405. 405. Okay? Cardiologist has just dropped, having a heart attack. The squad is called. They're about to start CPR. HDL 110. 110. Remember, my normal is 75. Through the roof. Triglycerides normally should be way low. Her triglyceride count is 118, 118. Not horrible. But there's no way on God's earth that someone who is this healthy in her diet should have a high triglyceride count of 118. It should be in the 40s and 50s. For example, my HDL is 87 and my triglycerides are 53 with a LDL cholesterol of 240. That's mine. Her LDL cholesterol is 269. So she's a lean mass hyperresponder. Okay, but she's got high triglycerides, so she's not a lean mass hyperresponder. She doesn't fit in Dave Feldman's group because the triglycerides are too high. How does that work? Okay, now we go down, we look at her other numbers. Blood sugar, 78. Early morning fasted blood sugar 78. That's low. How can those higher triglycerides be coming from a low blood sugar? Now remember, she's fairly lean. She's carnivore, but she's fairly lean. BUN 12. Too low for me. Too low. I like the 18 to 22. I would have probably, in a person of her size, 16 to 18 might have been okay, but she's at 12. Creatinine, which is another marker also of protein turnover, ideally I want that around 0.7. The guy's at 0.96, which is okay. Below 1 is okay for me. She's at 0.67. Low. BUN's low. Creatinine's low. Remember, she eats no carbohydrates. Just carnivore, protein and fat. So the only place her sugar can come from is from protein. Okay? And she's eating too little protein, and yet her triglycerides are high. And triglycerides represent the conversion of sugar to fat. How does that work? So let's go on. Electrolytes all fine for both of them, no issue. Liver numbers, which are the next. Now, liver numbers have a variety of things to do with them, but the liver is where you process, where gluconeogenesis happens, where you process amino acids and protein either to other proteins under the influence of insulin. So if you eat protein, if you eat meat, it becomes amino acids. Under the influence of insulin, your amino acids, your amino acids get transformed into protein, and we measure those as total protein, as albumin, as globulin, and those are liver function tests. They tell me how well the liver is functioning, but those are all normal for both of these patients. Absolutely normal, okay? The next thing we look at is alkaline phosphatase. And alkaline phosphatase, to a certain extent, tells me about inflammation of the liver. And typically, if you've got a fatty liver, and certainly an inflamed fatty liver, the two markers we look at is alkaline phosphatase and GGT, or gamma-glutamyl transferase. Both of those, gamma-glutamyl transferase more specifically, ALK-Phos less specifically, are markers of liver inflammation. My ideal ALK-Phos should be in the 50s. Okay? Low is good, high is bad. So if you drink alcohol, if you've got a fatty liver from alcohol or from carbohydrates, your ALK-Phos is typically going to be high. Well, the man's ALK-Phos, 33. Below the 50, actually low. And the girl's ALK-Phos is 26. The woman, okay, woman and man. 26, below the 50. So ALK-Phos is fine, no fatty liver. Well, at least on the other numbers as well. And then we look at AST and ALT, which are the two enzymes that convert the commonest amino acids, alanine and aspartate, okay? ALT, alanine transferase, and aspartate transferase, AST, into sugar. And ideally, I want those numbers to be in the teens. Well, the woman, it's 19 and 14, and the man, it's 18 and 13. Perfect. Perfect. When you are fat adapt, when you are insulin resistant, your AST and ALT tends to be very, very high. And if you are eating excessive amounts of protein, too much protein, your AST and ALT can also be high in some of our Sean Baker-like carnivores. Now, Sean's a different animal. He's huge. He's trying to grow muscle, about as healthy as you can be. But his AST and ALT are probably going to be slightly higher because he's turning over a lot of that protein to energy. These folks that are on the low side, for all three of those, no inflammation in the liver, no fatty liver, and their numbers are good. So what the hell's going on? Okay? Because we've got high triglycerides, and yet their sugar numbers are great. They're low. But the big sugar number is coming up in a few minutes. Okay? So in their urine, how do we corroborate this? In their urine, let's just see, both of them are in ketosis. They're spilling ketones in the urine. There's ketones in the urine, okay? They're low sugar, they're in ketosis, they're burning fat. Just 1+. It's okay, trace and 1+, male and female. So let's move on from there. Okay, so the ketones are positive. Now, this BLOODWORK's reported on slightly different pages. So we go to the next number, and this is the number that is the primary marker of average blood sugar. So your average blood sugar over the last 3 months is determined. That 79 to 78 is a blip. That's just what your blood sugar is right now. You get a fright or you drink some coffee with milk in it, and it goes up. I know I've got a CGM. I can track that. But your A1C is your average blood sugar over about 120 days. Okay, over time. And if your blood sugar is chronically elevated, that number is going to be elevated. And if it's elevated for long enough, that's called diabetes above 6.5%. My ideal for A1C is 5.2. So at an A1C level of 5.2 or lower, your A1C is no longer a cause of cardiovascular risk, of plaque development. Because A1C of 5.2 or lower represents typically a blood sugar in average in the 80s, where you are no longer, because of elevated blood sugar, causing endothelial inflammation. That's why those numbers matter, okay? Cardiovascular risk, and also nerve risk, damage to the nerves, neuropathy. So for both of these folks, the woman's A1C is 5.0, and the man's A1C, 5.0. Beautiful. Beautiful. So there's no way with a 5.0 for both of them that carbohydrates are contributing to vascular inflammation. So why the hell are their triglycerides high? Because ultimately, we look at high triglycerides as a marker of cardiovascular risk, as a marker of insulin resistance, as a marker of the risk that elevated blood sugar is going to contaminate your blood vessels. So if your triglycerides are high, it means your blood sugar should be high, but both of them have high triglycerides and low sugars and normal sugars. Why? Okay? And is this bad? Is this dangerous? Because we know high triglycerides correlate directly with, don't cause, but are directly associated with cardiovascular risk. So why are they elevated when all these other numbers are good? Let's look a little deeper, and this is blood work your other doctors will not order. Okay? So let's look at uric acid. And uric acid in the man is 7.1, high. Uric acid typically comes from fructose, it comes from cellular turnover, or it can come from protein breakdown. It's the third of the protein breakdown products, and it reflects, to my mind, the way I read it, as protein waste. 7.1 is high. My target is 5.5 or lower. So 7.1 is high. So this guy, even though his BUN is low, his creatinine is okay, he's lean, he's very lean, his uric acid is high. So he's wasting protein. And yet his sugars are good. So he's wasting protein. A little bit, okay? Or he's got some cellular turnover, he's got purines and pyrimidines going crazy, but he's at risk for gout and kidney stones, maybe. The woman's uric acid number is 4.5, perfect. 4.5, below the 5.5, absolutely fine. So he's got high uric acid. We'll come back to that. For both of them, their testosterone numbers, which is another marker of insulin resistance, perfect. I'm going to ignore that. Testosterone for the ladies below 0.5, which is where I wanted, 0.4 in a postmenopausal woman. His testosterone is in the 50s, kind of where I want to see it. So we're good. And that's a marker of insulin resistance. So let's go on. We'll look at it. I'm trying to find these next set of numbers. So the next set of numbers we're going to look at, and let me see if I can find these, is the, I'm trying to find them, the C-peptide and the insulin. So C-peptide for the man, 0.79. My ideal range is 1 to 1.2, 0.79. Almost falls in the category of a type 1 diabetic, 0.79, with an insulin of 3.4. 3.4 units of insulin, and a C-peptide of 0.79, but the reason it's not a type 1 diabetic, because that pathetically low amount of insulin is keeping his blood sugar at 79. And the woman, her insulin, 2.4, and her C-peptide, we did not measure a C-peptide. I normally do, okay? And her C-peptide has been super low before. For some reason, I didn't do it in this blood work, which is a little bit of a leave out for me. But at 2.4 on the insulin with a blood sugar of 78 tells the story. So normally, and that is called insulin sensitivity, or possibly even, and Ben Bickman and I understand this, most people don't, insulin suppression. Insulin suppression. But why are their triglycerides high? Why are their triglycerides high? Okay, so there's one other marker that's going to give us a clue, because the triglycerides are typically high when you're in a carnivore. Forget about the obesogenic people. Forget about in insulin resistance. The high triglycerides comes from your liver desperately trying to store and convert the sugar you're eating into fat. Okay, that's how we become fat, when you eat a lot of carbohydrates. These people are carnivore, have been carnivore for a long time, so they're metabolically healthy. They're insulin suppressed. So typically with insulin suppression, your body is using up so much fat because you're ketogenic and you're eating a high-fat diet that you're not using up your sugar. But typically, these folks are eating a decent, too much protein. Very often their BUN is in the 22 to 28, 30 range, so high BUN, higher uric acid, higher creatinine, because they're eating too much protein, and then the liver is turning that extra protein into fat, and that's where the triglycerides come from. However, okay, under those circumstances, the enzyme, or at least the hormone that turns that protein to fat, the gluconeogenic hormone, should be glucagon. And yes, for a lot of our overeating protein carnivores, their glucagon number then should be high. And most doctors never look at glucagon. Most doctors don't even understand what the hell glucagon is in terms of range and how it works. So we look at glucagon on both of these patients, and I measured it. And the normal range, the place I'd like glucagon to be in my recovering obese patients is low, but in my carnivores, I want the glucagon to be fairly high. So ideally in these folks, I would want the glucagon, I'd expect the glucagon to be high in the 30-40 range. Okay? Because glucagon should be their source of sugar. She's at 12. He is... What was his glucagon? I saw it here a second ago. So she's at 12, which is low. And his glucagon is 13. So, yeah, 13. So we have low glucagons, high ketones, low sugar, high triglycerides. How does that work? How does that work? Well, here's the issue. Here's the issue. Both these folks are lean. They're lean. They're not muscular, they're lean. So the problem here is that even though they're not eating a huge amount of protein, they're eating a moderate to reasonable protein, their BUN slightly on the low side, hers worse than his. And why is that BUN low? Because the BUN represents the turnover of protein to sugar. Well, if their insulin is super low, they're not adequately producing protein. They're eating a lot of amino acids, but insulin is the hormone that turns protein into, that turns amino acids into protein. And with that super low insulin, they are insulin sensitive, they're insulin suppressed. They're not producing adequate insulin to allow their cells, their muscle cells, to take up the extra sugar, even though their blood sugar is low. So their liver is putting out sugar from protein becoming sugar. The muscles are not taking that up. And even though the numbers are low, that excess triglycerides are coming from the conversion by the liver of a small amount of sugar to triglycerides, and their muscles are going to be somewhat glycogen depleted because their insulin levels are so low. They're not insulin sensitive, they're insulin suppressed because they're living on ketones. And their muscles are living on ketones, not on sugar. So what do we do for someone like this? How do we treat this person? First and foremost, take a break. Take a deep breath. Your blood work is about as good as it can be. So what's happened with them is over time, they have fixed the hole in the road that is insulin resistance. Okay? They fixed that hole, so there's no longer a hole in the road. Someone just forgot to switch off the flashing red light that is triglycerides. So their high triglyceride count in no way, shape, or form is contributing to cardiovascular risk. And certainly if you've had stents, if you've had significant cardiovascular disease, you're concerned about that, but it is not a problem because you don't have the inflammation from the sugar. So that's the first thing. Should you bring it down? I don't care if you bring it down or not, but if you want to bring it down, and here's the call to action, because the issue with these two people is that their insulin is too low. They are in the fat-adapted utilization phase, and they should never be there. They should be in the glucagon phase, not in the fat-adapted ketogenic phase. So they should be going from eating to the rapid deployment of sugar and a little bit of fat, but never into the starvation phase. And how do we fix that? How do we trigger that? You trigger that, paradoxically, by adding a little bit of sugar to the diet. And if you add a little bit of sugar to the diet, not to raise blood sugar, but to trigger insulin. And what is the trigger of insulin? The trigger of insulin is GLP-1. That incretin, that hormone in the gut that is triggered by Ozempic and Trulicity and Mounjaro that everybody's using for weight loss. Well, these people need to trigger GLP-1, but they don't want to lose weight. They're already a little bit too light. So the trigger for that is some form of sugar. And the healthiest source of sugar for these patients is dairy, is a little bit of milk. And that's my advice to them. So we will see what their blood work looks like, but I've started them on a glass of milk twice a day. Both of them can tolerate that. Both of them are comfortable with it. They don't have any issues with milk. They've stayed away from it because milk's so bad for you. A little bit of milk has got fat, it's got protein, it's got glycogen, it's got glucose and galactose, no fructose, which is good. No fructose, so no further injury to the liver from fructose, but it has the prerequisite glucose to trigger insulin release. And that is what we're after. And that will bring them back to insulin sensitivity. I am the Carb Addiction Doc. That is why we do blood work. That is why we read the numbers as a story, not as individuals. High triglycerides or elevated triglycerides are not always bad.